failing right ventricle?
Great question. I think in a lot of our therapies, it's multimodal. If the blood pressure is an issue, to me, a balloon pump may be helpful because remember the RV perfuses in systole and diastole. Second, I really think you need to be on with a PD inhibitor if your blood pressure can tolerate it. Milrinone is a very potent pulmonary vasodilator. The RV may or may not respond to that. And second, one of the things that's really, I think, beneficial in that setting is unloading the RV with either inhaled nitric oxide or inhaled prostacyclin. You know, inhaled prostacyclin is trickier to administer, but it's a lot cheaper, and I think it's a very useful pharmacologic therapy. The advantage of inhaled nitric oxide and prostacyclin is you get a localized pulmonary vascular effect and you don't see that systemic effects. The other thing when you're treating RV dysfunction is to carefully look at CVP. CVP in an ICU patient, to me, is extremely important because a lot of it's all about RV dysfunction. I think that's a great question.
Go ahead.
I'm sorry, Dr. Whitman, I mentioned the N-word nicardipine again this
time. Don't worry, I'm going to bring it up.
I apologize. But
no, I love it.
By the way,
it gives me a chance to say something.
It's generic, too, by the way, now.
So I just wanted to make the point that, first of all, I agree 100% with what you said about RV failure, but for those who aren't aware, nicardipine, which in some institutions has become a lot less expensive, can cost as much as $1,000 a day. And despite the fact that there was this it looked like a head-to-head with, I guess it's clevidipine, Jerry, I don't know that drug.
Clevidipine, yes.
To a panacea, there has never been a head-to-head with nitroprusside versus nicardipine. The advantages of nitroprusside, in my point of view, are that it's fast-acting. It goes away when you turn it off. Nicardipine has a long half-life, measured in hours. And secondly, it was costing us $1,000 a day on nicardipine as opposed to nitroprusside, where, in fact, you have to make sure the patient's volume loaded or you can really lower their pressure quickly. But with a little bit of practice, nitroprusside does extremely well in terms of lowering afterload and improving cardiac output. So I just wanted to make the point that keeping track of how much these drugs cost and what the alternatives are, I think is part and parcel of what we should be doing in the ICU. I think nicardipine is a great drug. I just think it's an expensive drug. And now that the patent's perhaps off and it's becoming less expensive, it might be a wonderful drug. But I just wanted to issue that caveat in a generalized way.
And I drink Dom Perignon every day if it weren't so expensive too, but good point, thank you.
Sham Sharif, Cardiac Surgery, Christiana Hospital in New York, Delaware. I'm following up on the question about the RV dysfunction and pulmonary hypertension, and vasopressin has been reported to have some beneficial effects in pulmonary hypertension, especially in congenital cardiac surgery. There have been a few reports from single center experiences around the country, and I would like to see your input on that.
So that's a great question. You know, Dr. Kotz and I learned many years ago at Mass General, one of the things if you have a left atrial line, and what people have used is left atrial norepinephrine infusion. Norepinephrine tends to be cleared across the pulmonary vasculature and taken up. The advantage of vasopressin, it seems there's less pulmonary vascular metabolism or effect, so it has more of a systemic effect. Honestly, you know, the vasculature is not as smart as we'd like to think it is, but I think obviously perfusion pressure is important. One of the advantages, again, of a balloon pump is you increase both diastolic, systolic perfusion pressures. But I mean, I think that you have to titrate it. And again, looking at CVP and see what's going on. A lot depends. The other thing, remember, when the patient's failing, think about an echo. And you can get a transthoracic, sort of just look at a transapical approach. You can get RV, you can get LV, and you can get a gestalt of, is the RV really dilated, or what's really going on? And when you start to that situation where you're perplexed, get yourself a quick transthoracic, or learn how to do it yourself with an apical, you know, just looking at a quick approach or TEE. It really gives you an amazing amount of information. There's also now indwelling TEE probes that you can use for up to 3 days in the ICU, which is really interesting for monitoring. They're pricey, but it's in a critically ill patient, it may be useful.
You know, you can understand why we had Dr. Levy here, and we're going to have to move on. And but we have a break, and Dr. Levy will be here, be able to answer questions for you. But that was very helpful, Gerald. Thank you so much.
Go ahead. You're already at
Okay. Terrific. Well, I'm delighted to introduce Ralph Damiano. Ralph is well known to cardiac surgeons from a variety of aspects, but one of his true specialties and areas of expertise are arrhythmias. And so, Ralph, thank you again for joining us. We're looking forward to your thoughts.
Thank you, Dr. Katz and Dr. Mulligan, and good morning. And what I'd like to talk to you about next is the prevention and management of postoperative atrial fibrillation, which remains really, after 3 decades of investigation, one of the most common, probably the most common complication, and certainly still a vexing clinical problem for all of us involved in cardiac surgery. I'd like to kind of review what the present state of the art in terms of our understanding of the incidence and epidemiology, but also talk a little bit about perhaps some of the areas where we may make progress is better understanding the mechanisms underlying postoperative atrial fibrillation, because in many ways I think we've been wondering a bit in the dark and trying a variety of different treatment algorithms, but I'll tell you from a clinical standpoint, very few of them have had an impact on our practice. We'll talk a little bit about risk factors, then discuss the voluminous literature on prevention and prophylaxis, and then at the very end quickly talk about the management of atrial fibrillation. As I said, it remains the most common complication following cardiac surgery, despite really years of both basic and clinical research, and I don't have to tell all of you who practice both in our ICUs and on the wards that it is a significant cause of morbidity and really eats up a lot of healthcare resources, and this has been shown over and over again. The incidence has remained remarkably stable despite what has been a plethora of randomized trials purporting to develop drug therapies for prophylaxis, and that even with the 24 randomized controlled trials, the incidence has been about 26%. It clearly happens more commonly after valve surgery, combined valve surgery, and coronary bypass grafting, with the lowest rates occurring after transplantation, and I'll probably describe to you a little bit of work that we've done in our laboratory which will explain that. The incidence, interestingly, and we've just published a series of about 15,000 patients looking at the last 10 years, the incidence at our center has been very stable at approximately 30%. And this is what we published this year in JTCVS, looking at a 20-year retrospective study of a little over 10,000 patients. And this just looks at the incidence both after all cardiac surgery and after coronary bypass grafting. If anything, there seems to be a slight increase recently, but basically a very stable level of right around 30%. And it's interesting, this is despite the fact that in mid to 80s, very few of the patients were treated with beta blockers and statins, where in 2011, I'm sure at all of our institutions, virtually everyone receives preoperative beta blockers and statins. The underlying pathophysiology really remains poorly defined, I think, and various different factors have been implicated causing atrial fibrillation. Our own predisposition has been that inflammation plays probably the biggest role, but autonomic dysfunction clearly has been shown in some studies. Patients with ventricular dysfunction clearly and long-term heart failure have many reasons to have both regular atrial fibrillation and postoperative atrial fibrillation. There's been a lot of literature on whether cardioplegia and the fact that the myocardial injury that occurs during surgery and perhaps the atrial swelling may cause it, though it's been very interesting recently, and we'll show you some work that even in experimental models, that basically the same incidence with off-pump coronary bypass grafting as with on-pump. So I think that risk factor perhaps has been overplayed, and there's some very good evidence that activation of the renin-angiotensin-aldosterone system. I'll share with you just a little of our work on inflammation, and this has been an area not only in our laboratory but others. I think there's potential progress in there. And we've shown that in an animal model, the degree of atrial inflammation is exactly proportional to an increase in inhomogeneous atrial conduction and the duration of atrial fibrillation, and the relationship actually is quite significant. And at least our feel that this may be a critical role in the pathogenesis of postoperative atrial fibrillation, and that an anti-inflammatory therapy therefore may have a real potential to decrease the incidence of atrial fibrillation. We just need to be smarter about how we deliver it. This is a study we did in dogs looking at a control group, a group that just had a pericardiotomy. We looked at then animals where we performed a simple atriotomy, which would be fairly similar in its length to just the cannulation for cardiopulmonary bypass, for instance. And then we had a group where we pre-treated them. These were with really large doses of steroids, pre-treated for 3 days before pericardiotomy and then continued afterwards. And if we just looked at myeloperoxidase activity in the right atrium here, and you can see that there is a pretty stepwise increase in both the pericardiotomy and the atriotomy group, and this can be prevented with steroids. Then when we look at those three groups, and you can remember the largest inflammation is the atriotomy group, and you can see that we used a pacing protocol, but basically we could induce continuous atrial fibrillation in virtually all the atriotomy group, and we had non-sustained atrial fibrillation. Basically, in 100% we could induce some evidence of atrial fibrillation, where in control animals and those with steroids, we never could induce any continuous atrial fibrillation. And if we looked at the probability of atrial fibrillation versus myeloperoxidase activity, which would be just a rough guide of white cell inflammation and white cell infiltration, you can see a very tight relationship. We've gone on to look at this quite a bit in more detail using optical mapping techniques in the isolated right atrium. And I'll just share you some stuff, but we actually were challenged to see whether non-steroidals, and I'll tell you they have no effect on this, but you'll see a group both. And what we did in this isolated perfused prep is basically, well, we first took a group of animals and either did nothing to them or made a simple ablation to mimic an incision in the right atrium. And then we had a pre-treatment group with non-steroidals. And then we brought them back 3 days later and isolated the right atrium and then looked at it using optical mapping techniques to see if we could really define the electrophysiologic changes. And this is a very simple, in fact, we found similar changes just by opening the pericardium and exposing the atrium to air can set off quite an inflammatory response, which may indicate why even off-pump surgery does. And I won't go into the optical mapping technique, but it's quite a powerful technique that lets you look at action potential, and our resolution is 300 microns, and new cameras can even get more down to the almost subcellular level, and we use a voltage-sensitive dye 4 and EPS, and we can really map the entire isolated right atrium, and this just looks at different action potentials. This is the right atrium, the right atrial appendage, the SVC, the IVC, and the area of the sinus node, and you can see we can get very nice action potential recordings. And I'll just show you what a simple atriotomy does. If I can get this to... There we go. And here we're just looking at 3 different panels. This is control, and with a single ablation, here's the ablation line here. This is activation, and it's an activation map where early activation is red, the pacing's here, and then as it gets later and later, you get to green and blue. And you can see a control, and these are all animals 3 days afterwards, a fairly fast activation. So the first thing you notice is conduction velocity slows. You don't see any green up here, where virtually half of this atrium is green and yellow, which is much slower conduction. But look at this. This is dramatic. The action potential duration is tremendously lengthened. Again, short durations are red and orange, and long durations are green and blue. A really dramatic lengthening of action potential duration just from a single little, again, this is the scar here that we created in these animals. You might say, well, that would be anti-arrhythmic, and what we found, which I won't really show you, is though at faster cycle lengths, we see the exact opposite in that you get a huge shortening of action potential duration as you get to faster pacing rates. And that appears to be the genesis of the proarrhythmic effect of inflammation in this model. We've got some other preliminary work which shows that there's tremendous, just by exposing the right atrium to air, that there's tremendous ion channel changes 3 days later in the ion channels of the right atrium to explain these changes, and I think this may be a very interesting target for drug therapy. But there's a lot of exciting research in this area that I think hopefully may actually get us a much more mechanistic approach to atrial fibrillation. There's numerous risk factors that have been identified for the development of atrial fibrillation. In yellow are the risk factors that we found in the series we just published, but I've also listed in white other risk factors that have been shown in numerous studies on this. But age clearly is the biggest risk factor. And if you are over 70, your risk is increased 5.6 times compared to a younger patient. Male gender, we found race to be quite significant in that for some reason African Americans have significantly less atrial fibrillation, and there probably is a genetic underlying to that. Hypertension increases your risk. A history of previous atrial fibrillation, obviously. In our series, we eliminated anyone from the analysis who had previous atrial fibrillation because they're really a totally different group of patients. Redo surgery, congestive heart failure, as I mentioned before, valvular heart disease, and clearly patients with left atrial enlargement. And I'll show you some very interesting data on that. So I think one of the areas we also could do much better with as clinicians is predicting those patients who have extremely high risk and really targeting them for more intensive prophylactic therapy. And this just looks in our study the relationship between patient age, shown on the x-axis, and the estimated probability of postoperative atrial fibrillation. But you can see as we're all dealing with older patients, up and particularly 80 is no longer that unusual, that by the age of 80 your estimated probability of atrial fibrillation is almost 60%. And these are patients I think we need to do a lot better job of probably being very aggressive prophylactically when it gets that high. This is also a really good paper from the Mayo Clinic where they looked at the relationship between age and atrial volume, and this is the percent of patients staying in sinus rhythm. And again, if you're over 65 and have a large left atrium, you really have a dramatically high incidence, and this is available to all of us, and I think we probably need to do a better job identifying these patients and targeting them perhaps for the really aggressive prophylactic treatment for their AFib prior to and around the time of surgery. There's been numerous other risk factors identified, which I'll just go through, but I mean, I'm not sure how much this helps us, but certainly COPD, peripheral vascular disease, renal insufficiency, and then others have identified obesity, LVH, and the presence of right coronary disease. That's probably the most controversial. There's also a number of postoperative risk factors, and one of the areas of interest to us is certainly anything that causes heightened inflammatory response, and infection can result in atrial fibrillation. I think we've all seen patients who have complications tend to have a much higher rate of postoperative atrial fibrillation, but MI, persistent CHF, respiratory failure, renal failure, and cardiac arrest, in addition to infection, have all been implicated in various studies to increase your risk of postoperative atrial fibrillation. The incidence is interesting and would go along certainly with an inflammatory etiology, with most common on postoperative day 2 and actually then receding. And as most of us know, that over time, in the vast majority of patients, when we see them back in a month, no longer have their atrial fibrillation. More than 60% of the initial recurrence occurred within 2 days of the first onset, and only 22% of patients experience more than a couple episodes. So it's a transient phenomena, but clearly we all know that it can cause quite a bit of clinical management issues. It's been thought to be a benign arrhythmia, atrial fibrillation, but clearly that has not been true. When big studies have looked at that almost all the studies have shown increased early and late mortality in patients with postoperative AFib. It clearly has been associated with stroke and prolonged hospital length of stay, and as I said, can increase both hospital and healthcare costs. One of the best studies that looked at that was a study published in JACC in 2004 of almost 6,500 patients, and in-hospital mortality was increased from 3.4 to 7.4%, and it was an independent predictor of both early and late mortality. The other impressive thing is that postoperative atrial fibrillation increased, the stroke rate was increased in those patients from 1.7 to 5.2%, so more than doubling of the stroke rate. Now, all these studies have been criticized that postoperative AFib may just mark the higher risk patients, but clearly, I mean, in study after study, it's been shown to be an independent predictor, and I think there is something to that. In terms of preventing postoperative atrial fibrillation, this is an area that is one of the few areas that is interesting because it's very evidence-driven, and that we've had a number of randomized studies, but I'll show you it's had very little impact on practice, which is an interesting phenomena. But there's many studies that are out there looking at preventative strategies for atrial fibrillation. And there's been meta-analyses, and I've quoted one, and it's in your booklet, which showed that prophylactic treatment to decrease AFib reduced hospital stay and cost, but didn't have an effect on stroke. I'll show you that that was an overall look at a number of different strategies. There's actually been some randomized studies which showed that that's been an impact, but there's been numerous drugs studied for their preventative effect. And I won't review all of them, but I'll just review probably the ones that have had the most impact on clinical practice. And the first is beta blockers, which I think we all use and tell our fellows that this is a very important part of our management to prevent postoperative AFib. And in various meta-analyses of randomized studies have shown the effect approximately halves the rate of postoperative AFib from an incidence of, in the incidence where I've quoted, of about 33 to 19%. It has an added benefit which has been shown from the STS database studies of reducing perioperative mortality, and their current guidelines strongly recommend preoperative and postoperative beta blocker therapy for patients undergoing cardiac surgery to prevent AFib. Amiodarone also has been another drug that has been, I think, very successful in randomized trials, but I think is one of those drugs that's interesting when it gets to clinical practice, much more difficult to use because of all of its side effects. But the largest trial of amiodarone prophylaxis showed that it was effective and safe and had a benefit over the use of beta blockers alone. And it's been shown to be the combined use of oral and IV amiodarone versus placebo alone in the APHIS-2 trial showed that a reduction of approximately 39 to 22%. You'll see over and over again, these studies tend to show about the same reduction, but that hasn't really, you'd think we would never see postoperative AFib anymore, but it's been, but that's really not been the case in clinical practice, and one of the problems of using these drugs. It's the only drug that's been shown to reduce the incidence of postoperative stroke. So that's interesting about amiodarone, and certainly we use it a lot in our center. I'm sure all of you are using it. It's been well studied in multiple meta-analyses, and this is where it's interesting, is that it seems to be effective despite a wide variation in the different studies of dosing, scheduling, and route. And there's been really no significant difference found between either high or low dose regimens and between preoperative and postoperative initiation of treatment. I won't go through the numerous other drugs that have been looked for the prevention of postoperative AFib, but they include sotalol, magnesium, statins, fish oil, which we're involved in a study, polyunsaturated fatty acids, anti-inflammatory drugs, and even temporary pacing. But none of these treatments yet have had the effective, have proven to be effective with the same robustness of both amiodarone and beta blockers. And the data in these studies have been sometimes conflicting. So I'll end with just to talk about the management of postoperative atrial fibrillation. And the goals of that is clearly first to assess for hemodynamic instability, second, differentiate fibrillation from atrial flutter, and then initiate rate versus rhythm control. While we've had a huge amount of randomized studies on prevention, it's been interesting, an area that I think really could use a good study, and we have a lot of patients where we could look at that, is the rate versus rhythm control strategy, which I still think is an unanswered question. And certainly hemodynamically unstable patients, electrical cardioversion is the mainstay of treatment. We have sort of a semi-elective cardioversion protocol where we we'll contact, a lot of time our critical care physicians now do that. We hold them MPO for a few hours and then usually use some IV midazolam or another mild sedation and then perform the cardioversion. And clearly this is an important part of the management of those patients who are unstable. In terms of differentiating atrial flutter, the diagnosis of atrial flutter is best made by obtaining an atrial electrogram, which most of us have from the wires we put on at the time of surgery. And simply by getting a good recording, and this is just a recording from these atrial wires looking at sinus rhythm, where you see the atrial spike followed by the V spike, and this is in looking at a unipolar electrogram. Now, if you look at a bipolar electrogram, when you look at just the two that are on the atrium itself, you'll see just a single spike representing atrial activity, a sharp spike, followed by just a far field activation representing the QRS. Now, in atrial flutter, and I talk type 1 atrial flutter, which is the slow atrial flutter, usually with rates of less than 350 beats per minute. It's important to differentiate. It's the slow flutters that usually can pace terminate, which I think is important, and that's an easy thing to do and can be done almost instantly. And interestingly, flutter, because usually the ventricular conduction rate is higher, is often much more symptomatic for a patient than atrial fibrillation. But just from a simple atrial electrogram, you can make this diagnosis. Now, type 2 atrial flutter acts from a treatment standpoint, which is the fast atrial flutter, is much more like atrial fibrillation and usually is not responsive to a rapid pacing protocol. So in patients with atrial flutter, we usually will consider rapid atrial pacing, and you can begin, how we do it, and there's many ways to do this, is begin with burst pacing at twice diastolic threshold and a rate of about 10% above the flutter cycle length. So just calculate the flutter cycle length from the atrial electrogram, increase it by 10%, and then we ramp up in increments of 10% until flutter's terminated. Now, the interesting thing with this treatment strategy, which can be done immediately, and I think is much certainly does not have the complication or cost of cardioversion, is if it's not effective, in slow flutters it will often be effective at restoring sinus rhythm, but if it's not, it usually does convert the patients to atrial fibrillation, which is usually better tolerated, and you can then proceed with a drug regimen and usually don't have to worry about cardioversion. So I think it's an interesting strategy. Now, on your atrial electrogram, atrial fibrillation can look quite different in terms of how it looks, and can often look, just regular activation can still be atrial fibrillation. You have to have atrial flutter, you not only have to have regular activation, but your atrial lead morphology has to be identical beat to beat. You will have types of atrial fibrillation where you have regular activation, but the morphologity changes, and that would still be considered atrial fibrillation. But this is a classic example of what most of us would consider atrial fibrillation, with a very irregular and changing morphology. But just to warn you that atrial fibrillation is sort of like causing, you know, for someone who treats a lot of it, preoperative atrial fibrillation is a huge spectrum of different arrhythmia mechanisms that underlie this. It's sort of like just calling something cancer. There's many different phenotypes of AFib. But in the hemodynamically stable person, certainly there's no reason, and we do not proceed with cardioversion. There have been some people who've advocated that, but again, that's an area that hasn't been well studied. But really, our first goal is to control the heart rate. And there's several strategies for that, but generally in patients with good ventricular function, we prefer diltiazem, IV, and then an IV infusion, and it can be increased in 5 milligram increments up to 20 milligrams per hour. And this is, I think we find it a relatively safe drug and can be used on the ward for treatment. Never been a fan. I mean, some people advocate use of intravenous beta blockers, but I find that not to be very, in terms of doing that, I think it's appropriate in an ICU setting. I don't find that to be very safe on a ward setting. For patients with really poor function, DIG is another option. Not an option we do very often, but certainly can be done and can give you rate control. It just takes longer. For patients that persist in AFib after an hour, despite adequate rate control, you can consider initiation of rhythm control. We tend to be, and have gotten quicker with probably initiating rhythm control strategies, and our drug of choice has been amiodarone. and usually with an IV dose of 150 milligram followed by a PO load of 400 milligrams TID. And those of you know that amiodarone has a ton of side effects, and you have to watch both for thyroid function, and it can have hepatotoxicity effects, and certainly both of those probably not that important for the short-term usage that we use it for the first month after cardiac surgery. But the thing that you can see in short-term use is prolonged QT interval, which predisposes patients to proarrhythmic effects. The contraindications to amiodarone are listed here, and I think involve any history of toxicity, junctional rhythms, significant high degrees of heart block or severe bradycardia, and it does have a beta blocker effect. In patients with poorly controlled thyroid disease, it's probably, because it is a thyroid homolog, is not a drug that you probably want to use. The precautions, which often are forgotten about, is you really have, if they're on DIG, we usually discontinue digoxin in patients. We use amiodarone. I think it's not worth it. They have a lot of drug-drug interactions. But the drug that we often use with it is Coumadin, and you should, if they're on chronic Coumadin, half the dose when you start amiodarone, because you'll definitely prolong your INR. Again, this is our predisposition. Washington University, this is an area, again, that there hasn't been a lot of studies like when should you begin anticoagulation, and we certainly see complications from anticoagulation, and it's hard to know, but we certainly still believe that the worst complication you can have from AFib is a stroke, and we're very aggressive to prevent that, and we do, if they're in more than 8 hours, initiate anticoagulation. So just to summarize, this looks at 72 studies of almost 56,000 patients by year and the incidence of postoperative AFib. So despite all I told you about these great prophylactic drugs, it's virtually had no impact on clinical practice. Or certainly you can see clinical practice, the incidence in published studies varies widely. So we, as a profession, are not doing a very good job with this. And despite, this is just one example of a 2010 paper, and despite a lot of patients being on beta blockers and statins, it hasn't seemed to impact the incidence of postoperative AFib. And not only that, is the distribution of patients who get postoperative AFib doesn't seem to be significantly impacted by whether those drugs are present or not. So here is a disconnect between what we have published and what seems to be clinical practice. And as this cartoon says, it's fine to discover cures, but remember, chronic conditions are our bread and butter, and certainly for my life as a cardiac surgeon, postoperative AFib has been bread and butter, but I'd love to get rid of it. But I think we need to do quite a bit more work. So in summary, postoperative AFib is common. It's associated with significant morbidity and mortality. Prevention of postoperative AFib is difficult despite all these randomized trials we've had and a variety of different drugs. That successful treatment requires both rate and rhythm control, and I think it's an area really desperately in need of further research to define the mechanisms of postoperative AFib in order to develop more of a mechanistic approach to prevent it. Thank you very much.
Boy, that's a comprehensive, updated view. Thank you so much, Ralph. That is a tremendous presentation on this problem. Should we, if there's, we're a little bit behind and we'll move along. Dr. Damiano will be here during the break. But thank you so much, Ralph.
It's been my experience that, my unpleasant experience, to watch residents and fellows from a variety of institutions get pummeled by various attendings because they don't quite understand what's desired in the management of postoperative VAD patients. This is an area of rapid growth, but unfortunately I don't think we've done a very good job of keeping pace with the curriculum for how to teach people how to take care of these patients. We're very fortunate today to have Dr. Lyle Joyce joining us from the Mayo Clinic. He was, as some of you probably know, one of the PIs on the ventricist protocol as it was developed, and is renowned in the field for being not only an excellent surgeon but an excellent educator. And when we were putting the program together, he was the unanimous choice of the committee to lead us in this area. So we really look forward to your talk, Dr. Joyce.
Thank you, Dr. Mulligan.